Well, hello, everyone. My name is Mickey Eisenberg, and I welcome you to our next podcast. And today's guest is Dr. Lance Jobe. Dr. Jobe attended the Resuscitation Academy 10 years ago. He comes from a relatively rural part of Washington State. I'll let him tell you a little bit about it. But he really faced some unique challenges, and I'm going to let him tell you himself. So, Lance, welcome to the podcast.
Thank you,
And
Mickey.
let me start out by just saying, great to see you again. We see you every year when you come to speak at Resuscitation Academies, but it's nice to see you for this podcast. So you come from a relatively small community. You're the medical director for 2 counties. Tell us a little bit about your community and the unique challenges you faced in dealing with cardiac arrest.
So thanks, Mickey. It's good to be here as well, and good to see you again. So we're right in the middle of Washington State, and the area is quite large, almost 4,800 square miles, and the population we serve is about 115,000 people. And we have a mix of, a large part of the population is in a small area here in Wenatchee and East Wenatchee. But then we have people kind of scattered all over the county, and then even really quite wilderness areas. We have 21 EMS agencies that serve that population. 4 of them are ALS agencies, and our fire departments are almost all volunteer. We have 3 that do have career firefighters, but most of them are volunteer. So of course that kind of brings up a number of challenges for rural communities as well. But that's kind of the overview of our system.
What were you facing when you decided to come to the Resuscitation Academy? Did you know what survival rate was in your county? And if you didn't, how did you go about finding out?
So yeah, we were pretty much at ground zero. I did not know what our survival rate was. I think our approach back then was, we followed the, ACLS protocols and, did what we thought was the right thing for cardiac arrest. But honestly, it really seemed kind of like a roll of the die, whether somebody lived or died. And we didn't really have any QI process. We weren't following the numbers. And so it was an eye-opening experience coming to the Resuscitation Academy and seeing what you were doing in Seattle and other people in other parts of the state gathering data. And so I did go back to 2010 and kind of a retrospective look at our data. And for Utstein criteria, we found 10 cases of which 2 people survived. And so, if you can take that, we had maybe a 20% survival rate, although, retrospectively looking back, we might have even overestimated that survival rate. So that's kind of a ballpark maybe of what our survival rate was then.
What did you do first? How did you even decide what you wanted to do first? Because it's just you as the medical director. You didn't really have much help at that time. How did you tackle the challenge to improve survival?
Well, I felt like the lowest piece of hanging fruit was high performance CPR. And we had one other medic who had gone to the Resuscitation Academy earlier that year in the spring of 2010. And so he was pretty excited about, some of these changes, potential changes. And we had another medic who kind of grew up, if you will, in the Seattle Medic 1 program. And so the 3 of us kind of got together and essentially went and trained all of the agencies in high performance CPR. I did my best to try to give a condensed version of Dr. Kudenchuk's talk on high performance CPR. Really felt that it was important that people understood why we were making this change. And I had a number of, longtime career firefighters that later came up and said, when we heard you were making this change, we're like, okay, whatever, we see these changes every 5 years with the AHA. And they really didn't have any high hopes, or expectations of that. But I think it helps to try to give them the perspective of why we were doing the change, and then following up with them to see how are things going, and showing them the numbers, and so people got pretty excited about high performance CPR, and they also liked how they knew exactly what they needed to do. There was no questions about who's doing what, and so they were very comfortable with the process. And then as they saw results from that, it kind of became this self-perpetuating success, if you will. And so that was our first start. It was a lot of time going around to all the agencies, training them, and that was all volunteer time. There was really no budget for that, so the three of us did that training. So that was our first. And I would say the second we did at the same time was we started measuring data. So we got onto the CARES platform, and starting January 1st of 2011, I started collecting every single cardiac arrest case. I had the medics call me with every cardiac arrest, and they have to fill out a CARES form that we then later enter into the system.
Before we get to results a little bit, which I'd like to hear what happened, how did you get help to do this? Was it all volunteer help, or were you able to convince the fire chiefs that this was worthy of some concrete support?
So one of the things that I really wanted to do was, well, I had several projects I wanted to work on besides the high performance CPR. But one of the things I wanted to do was to do mannequin CPR, and so that we could evaluate, the firefighters with the quality of their CPR. Because one of the challenges that we face in rural communities is experience. We have, firefighters that are volunteers in some agencies. They may only have one cardiac arrest a year or less, and so some of them have never even done CPR on a person. They've only done it on mannequins. And so because of that lack of experience, we wanted to help standardize that with mannequin CPR. But of course, yes, I needed help to do that. And so I pitched to the fire chiefs an idea that they would all contribute some money to our local EMS council to hire a person, part-time position, that could go around to all of the fire agencies and assess the firefighters with their CPR. So looking at their rate, depth, recoil, and then actually doing a mock code and looking at their CPR fraction. And then we use that as a little competition between, shifts with the fire department, or, in the volunteer agencies, just their whole department, versus other departments. And we would give them an award every year for the highest, CPR score. And so I think that's been kind of a fun thing for us to do, and just kind of keep an eye on quality. And it's, it was, the other thing that I had that officer do was start doing the defib downloads. And so we were able to get some grant money and purchase the software and start downloading the codes and be able to give feedback. And that's been just super valuable to be able to, give them kind of a score sheet of, some of the metrics with their CPR fraction in an actual case. What went well, what can we do better? And sometimes I'll even sit down with them and they'll review their own recording, and they can kind of pick out what went well and what didn't go well and how they can do better the next time.
So Lance, I've been impressed with the results of what you've done. Tell us a little bit about the results. How did you do in terms of starting at 20%?
So I think another challenge for rural systems is sample size. So our numbers are low, and if we look just at Utstein criteria, so those bystander witness with a shockable rhythm, we probably average only about 12 a year over the last 10 years. from 2011 to 2014, we averaged 39% survival to hospital discharge. So I think we had a 20% increase in our survival, primarily with high performance CPR and with our DFib download program, and just really doing a lot of quality improvement with that in our folks. And then in 2014, we started having collaboration with our dispatch center. We also developed a program, started a program with the Chelan and Douglas County sheriffs to put AEDs out in all the cars and have a protocol. But with our dispatch program, we really focused on aggressive telecommunicator CPR, started a QI process where I review all of those cardiac arrest 911 calls. And so we look at some of those metrics, give feedback to the dispatchers. They also put a process in place really to try to reduce dispatch times, which they dramatically reduce those times, and we follow that as well. And so the interesting thing is to go back then and look at our survival from 2015 until through 2019. And our survival over that 5-year span is now, I haven't calculated exactly, it was 57% through 2018. And we were a little lower in 2019, but I think we're at about 54% for that 5-year period. Wow. So kind of exciting to see, those numbers go up with these different programs that we've put in place.
Well, I gotta admit, I'm impressed. And there have been some years when, and admittedly, these are small numbers, but even when you group them together, you have performed as good or some years even better than the King County Seattle system. And I think that's absolutely astounding. It says to me that you started out based in science on 2 programs, namely telephone CPR and high performance CPR. And you implemented it, and you implemented them beautifully. But the other thing that was really behind it all, which is one of the higher hanging fruits in our 10 steps, is that of leadership. You provided leadership. You came to your organization and you looked at it and you said, we can do better, and here's how to do it. I've got the tools to make it better. And you did. And you provided feedback, and everybody's bought in, and now that's your new normal. It's just absolutely astounding to me, Lance, what you could accomplish. So any final words, any challenges for the future in your community?
Well, I think, I think money is a challenge probably for all of us, but I think in rural communities, it's even a larger factor. And my hope someday is that we could actually get public funding for kind of an EMS oversight, kind of like the Seattle Medic One Foundation, and be able to really support more programs even beyond cardiac arrest care within our EMS system.
Well, the simple steps of training, collection of data, providing feedback to the people who provide the service, and leadership. What a powerful combination that is. So Lance, I want to thank you. You've done amazing things in the 2 counties of Chelan and Douglas here in Washington State. And I hope it can serve as a real beacon for medical leadership in smaller communities. You can really dramatically change your system with some of the lessons that Lance has demonstrated. So thank you very much, and keep up the great work you're doing in Chelan and Douglas County.
Thank you, Mickey. And, we couldn't do it without you. You kind of give me the energy every year when I come over to Seattle. It kind of, gets me going again for another year. So I appreciate all the help that you and the RA give us here in Chelan and Douglas counties.
Well, thanks, Lance. You are the poster child for small communities. Way to go. So thank you so much for being in this podcast. And just can't thank you enough for the great work you've done. So long, Lance.
Bye, Mickey. Have a great day.